G'day everyone. Welcome to the latest edition of Infection Control Matters.
Take two, because we've got through the first 10 minutes of this podcast and realised it wasn't being recorded. And it's not Phil Russell's fault this time either.
No. So obviously you can hear Martin in the background. G'day, Martin.
Yes, hanging head in shame.
We've got some great guests with us today, Jessica Schults and Sally Havas. G'day, Jess and Sally.
Hello. Hi, Brett and Martin.
Now, for some context, Jess is a senior research fellow at the University of Queensland. Sally also has an appointment at the University of Queensland in Australia and also appointments with the Queensland Infection Clinical Network and the Darling Downs Health Service. And I would, of course, preface this like we do many talks that are not representing their organisations in this chat. So welcome, Jess and Sally. Great to have you with us. We're going to be talking about a paper that's currently a preprint in the American Journal of Infection Control, and it's called Expert Consensus and Recommendations for Healthcare-Associated Infection Surveillance in Queensland. And I guess maybe, Jess, we might start with you and just want to give us a little bit of context as to why this sort of topic and issue came about.
Yeah, thanks, Brett. I've been interested in quality and safety measurement for some time, and I know I'm not meant to say that word in conjunction with infection control, so I'll just skip right past that. Coming from an intensive care background where there's quite established surveillance systems, when I came across infection control, I was surprised to see that infection control really lacked the infrastructure and support systems for standardized surveillance of infections across the state, and that was having some big impacts in terms of aggregating data and how they were able to target their prevention activities. So that really drove the interest in this topic.
And just for context for our international audience, Australia being one country, but is made up of many states and territories, and it's a federation. And essentially in that, it means that in the area of health and hospitals in particular, I should say, states have primary role for hospitals, including their management and governance, and primarily the main funders. So traditionally that has meant that different states can do what they like when it comes to hospitals within reason. And over time, that variation was huge. It's starting to become a little bit less, but that extends to infection prevention and control. So hospitals within states will need to follow national guidance, but also what their state government is telling them. And often surveillance is being led at the state level. So there's variation in surveillance definitions and surveillance practices. And we were talking in Mark 1 about this a little bit more too, of this podcast.
You're going to keep rubbing it in, aren't you? You're really going to keep rubbing that
in. This issue of standardized surveillance, Jess and Sal, has been an ongoing issue, and I called it a battle previously, with this huge variation that goes on in infection surveillance.
Yeah, I agree, Brett. It's a real battle. And I have to say, in Queensland, we were really up against it because we hadn't had a statewide infection prevention and control service for over a decade. And so not having a national approach meant that it was literally every health service for themselves. And so that variation was huge. And it also makes it really challenging for infection control professionals who might be newer to the area. There was no validation of data or process. So it had really pushed all of that down to the most local of levels. And that variation in practice, the standardization, there just wasn't anything or any guidance for people. So it did make it was a real challenge and a real battle on the regular for all of the IPCs in that circumstance. It is very challenging not having a national surveillance system or surveillance approach and standardization, because we can't compare apples with apples across the country. And I think we saw that with COVID. There was, real differences across the state in how COVID was measured, and how the numbers were recorded. And so, yeah, it is definitely a challenge in Australia to bring uniformity to what we do. So that was another real, gap for us in Queensland for sure.
Now, Jess, you say you're new to infection prevention, but you've got an ICU background and you have standard systems there. So what sort of data sets were being collected there? How was that gone about? And is that national or is that statewide?
Yeah, so the ICU registry has been around for decades and it spans Australia and New Zealand. Their minimum data set is typically collected by a data collection manager at the end of a child's intensive care admission. But I think the one benefit that ICU has is that most ICUs, and that's a large caveat, there are some still on paper, are all electronic. So the data is routinely collected in an electronic fashion and it's easier to pull. You can only really select the options that are in the drop-down box. So it's been a bit easier to collect measures, surveillance measures, but there haven't been many infection measures collected in the ICU. There's a predominant focus, as Sal said in the earlier recording, on SABs, and CLABC is also another big one for ICU with their central line utilisation. So there are some definite learnings we can take from fields like intensive care in terms of standardising surveillance.
So do the infection prevention teams use the data that are being collected in critical care?
They often check on us, to be honest, to check our classification of the CLABCs in particular. We generally have a really good collaborative approach to the infections that arise as healthcare associated in the ICU because they typically have such an impact on length of stay. So, yeah.
There's not much arguing about
I
them.
would certainly say... No, and I would certainly say in the units that or the organisations that I've worked in, most have had quite a connection to that data that's collected. So you're collecting the same data in a sense because we're obviously collecting central line data and days and those sorts of things. So might be different data, but generally it was a fairly collaborative approach in my experience anyway.
I think the one measure that is really glaringly obvious as something we need to work on is pneumonia, particularly ventilator-associated pneumonia. And Brett, I know you're doing a lot about hospital-acquired pneumonia, but I will prattle on about this until I leave this earth. We need to find a solution.
There was no way we were getting through this without her
You
saying
know there's questions coming.
Can I tell you?
This,
Can I tell you? Okay, good.
I've got a few in my brain.
Okay, great.
Preparation.
I'll get on my soapbox.
We're on the money there. Well, I'll hold those back. But do you want to just give us a bit of a rundown on the sort of methods you used, the question you wanted to explore, and then the method you used to do that, this study?
Yeah, so I think this method is really great for somebody who has methods expertise and you're wanting to bring together all the clinical experts, because as I mentioned, this isn't my field of expertise. I certainly have some understanding of it, but we needed to bring together all the stakeholders who were then going to use the surveillance data set, because we could get a group of 5 people together and pick some measures, but they were never going to use it and it was never going to translate. So we chose the Delphi method because in the first instance, or the first phase of the methods, you can sample from everybody. So in IPCs, microbiologists, infectious disease physicians, your end users on the clinical floor, and you can ask them about their experience, what they think is important, useful, and feasible in terms of measures to collect. So that was really important for the team from an engagement side of things. And then the second phase of the study in the Delphi was really great because then we got the experts together and they were asked to reach consensus on a core data set. So a minimum number of measures that we could use to surveil infections across the state that were usable, but particularly could be used to drive prevention activities, because the focus of the Delphi was to prevent these infections from occurring.
So is this for the outcome is what measures, what surveillance indicators should be there for public reporting or internal reporting? Because there is a difference, I think.
Yeah, Sal, did you want to take that, or do you want me to? That's a great question.
It's actually internal reporting. At this point, it's internal, and that it was for the purposes of internal reporting. There is a little bit of difficulties or challenges because we are in Queensland also a divulged state. So each health service is their own entity. So there is a lot of argy-bargy, if you like, around who owns the data and how data is shared across the state. So in the very first instance, this is really internal use. Certainly for the purposes of this study, there was no discussion around it being publicly reported, but that would be something that each local health service could choose to do if they wanted to, I guess, in theory, but for the purposes of the study, it was only internal. With the background, of course, that we had no guidance and no statewide direction in terms of surveillance methodology for a decade or more.
To be fair to the IPCs participating, when you spoke to them, there seemed to be quite a divide. There was a proportion of people who really felt strongly about public reporting and consumers' right to see the rates of infections at each site and therefore choose the, in particular, private healthcare, but we didn't include private. And then others who were very worried about what that meant for future fiscal penalties. So if the financial penalties would increase, if they could see that there was a vast difference between health service provision and rates of HCAIs. So I don't think we've solved that issue at all. Actually.
I'm wondering why that would bother an infection preventionist, though, because that to me that's more, more grist to your mill, if you like. It gives you more of an argument if your organisation thinks it's going to be financially penalised. It might actually, because to me, managers don't move very far. They're like a wheelbarrow; they don't go anywhere unless they're pushed. And if they think they're going to lose money, they may be more interested in infection prevention. I know when we put fines in this country, in the UK, on MRSA bloodstream infections, suddenly chief execs got quite interested in this because they were going to be fined for missing a target. And I'm not saying setting a target's a good thing, or I do, but we had a particularly big problem that we gave ourselves. So I'm just, I'm interested in why an infection preventionist should think a fine is a bad thing. And is it because it would put pressure on the team? Because that's actually what happened here. But it's actually the organisation's problem, isn't it? Not the infection preventionist problem.
Yeah, I think too the other issue, Martin, is it definitely is detrimental more to a less experienced IPC. I think if you have people who have been around for a little while and who, I think it might be your saying is, never let a disaster go by without making the most of it. I think people who are a bit more experienced, infection control people who are a bit more professionals who are experienced, aren't as scared of the bad publicity or concerned about that. But we do have quite a number of less experienced infection control practitioners, and quite a number of them are in our regional areas in Queensland. And so for them, one, the system hasn't necessarily been there from the time that they've been working this space, so they're kind of winging it and they're kind of making it up as they go along. And second of all, they will bear the brunt if there's a problem. So if those, if there are infections, it's not necessarily understood to be an organisational issue. And so, it's really about, for me, around that support for the less experienced IPC in that sort of space. But I'm with you. I think there's not enough focus on it at an organisational level. I say bring all the fines. We shouldn't be giving those people the infections anyway, but that's just me.
Of course, Phil Russo, part of this podcast a few years ago with his PhD, used discrete choice experiments to try and evaluate some of those nuances between surveillance definitions and surveillance approaches in terms of time and cost and penalties and all those types of things. And that was a fascinating piece of work. But back to your piece of work, Jess and Sally, I might start with, well, I'm going to work backwards, because what I actually found interesting in this paper was some questions you asked about, which I think was the first part of the survey, first stage one, correct me if I'm wrong, about importance, feasibility, and usefulness. And in the paper, you describe those I really like that graph, actually. It's really managed to get so much into one graph and really well presented. Now, the thing that struck me, the importance. So the importance of these infections, and some of the ones that came up the highest were Candida aureus, CPEs, bloodstream infections, Klebsiella, and Staph aureus bacteremia. I guess there's an interesting point that SABC was separated from bloodstream infections. But the thing that struck me, Jess, you would be very surprised I'm going to ask this question, is pneumonia. And pneumonia ranked the least important, and again, correct me if I'm wrong, it's equal least important of all the different surveillance options out there. And that list is extensive. I'm going to say there's 20 odd things on that list. And it was considered probably the least important by those who responded. Am I interpreting that correctly? Any thoughts on that?
Yeah, so general hospital acquired pneumonia and VAP did not do well because basically only 4 people wanted to answer it because everybody said, it's not feasible, we can't do it, we shouldn't do it until you make it easy for me. So I'm not sure it's generally reflective of all clinicians' views, and that's a significant limitation of the paper. We did only sample infection control professionals and ID and micro. If you were to go out to the other fields, I think pneumonia would rank higher, particularly in cardiac surge. I think post-op pneumonia rates in that population is very high in the intensive care units. So I would take that with a grain of salt.
Yeah, okay, that's good. Because I kind of thought, where have we missed the boat here? Because, there's reasonable evidence that, in fact, pneumonia, of all the infections that we have, including bloodstream infections, is more impactful because of the volume and the impact in terms of mortality, morbidity, length of stay, and long-term disability. And it's probably the infection, if you were going to say, arguably is the most important one we should be preventing for the biggest impact. What are your thoughts on that? Would you agree, Jess?
I'm going to jump in slightly here as well. And
I've got so much to say, Martin.
Yeah, I'm sorry. But I just want to jump in very briefly.
Let's not decide all the evidence.
Something you said about others might think that's more important than we do.
No, not me.
But others outside of infection prevention might be more interested in cardiac. And sometimes I wonder if we're very good at talking to ourselves about our problems rather than actually asking our clinical colleagues, okay, what would you like good data on? Are there things you are concerned about? And I don't think we do that enough, because if we can sometimes be very good at producing data that says somebody has a problem, but if they don't think that's a problem, they're not going to be that interested. Whereas if they're asking you, actually, could you collect some information on that? That might actually be more useful from a practical point of view, because they're more likely to engage with it. So I just wondered about that. Do we talk to ourselves too much about what we think is important and not ask our managers what they might want some data on, or our surgeons what they might want some data on? Although surgeons generally have an infection rate of 0%, I know that. But do we engage with others enough, do you think?
No, I don't think we do. But I'm a massive hypocrite because I didn't engage with them for this. And there's a number of reasons for that. But I think if we come back to that discussion of national surveillance, it has to be that we go to the societies, we ask for input, and we do a massive broad scale engagement project to see if we can get any agreement on, even if they have one infection that they'd like prioritized in a minimum data set. I think what's really interesting is when we talk to consumers, and we've done this work in the peds space, I haven't done it in adults, parents are most scared of pneumonia, because what happens when their child gets pneumonia when they have a tube is the doctor says they're going to be ventilated for longer, they're going to need a whole lot more antibiotics, and they're getting a lot sicker. And so when we survey them about their number one concerns, pneumonia and bloodstream infections comes up time and time again. So I agree with your assessment that pneumonia is really important, both hospital and ventilator. I just don't think we have a solution of how to do it. So people are just like, it's too hard, put it in the too hard basket.
Do you think that's do you think it's our own bias that's influencing that result? Is it because we don't know that it's important, or do you think that it's because it's too high, we're just going to say it's not important?
Can I interject there, Brett? Because I would have ranked it not low for importance, because I work with Jess and she talks about pneumonia every day of the week. But I don't so this is a very personal view on it. But I don't feel like I can make a difference there as an ICP currently. It's not an area of focus for my organisation. They do not ask me questions about it. It's in the too hard basket for them. So whereas I feel like, at least with the CLABSI or even BSIs in general, I feel like I can probably make a difference in some extent, and I don't know, because there are good guidelines in pneumonia prevention, so it's an interesting. Well, not in Australia.
Jess doesn't agree.
No,
Jess doesn't agree. Jess is saying no. So maybe
can I just say,
issue,
can I highlight something you just said there? And I realise this podcast is not about pneumonia. I'll stop. But
that's all right. It goes with tangents.
Listen, it was always going to go this way.
And SABS had the rates that pneumonia had, and the outcomes are relatively on par, if not worse, for pneumonia, the government would be throwing money into CLABSI prevention activities, registries for CLABSI, which already exist, but they'd be reinvesting. No one's doing anything for these horrendous infections that have horrendous outcomes. Like, we have 40% mortality rates in VAEs. Like, it's insane. But anyway.
Yeah. Yeah. Hospital-acquired pneumonia, if you get it, 6 times more likely to go to intensive care and talk about the things that you just had.
Yeah. We're very friendly in intensive care.
I mean, you mentioned
VAEs.
VAE is based on data you're routinely collecting anyway.
Yes.
And if you're electronic, how come surveillance there is so difficult then if you were to do VAEs and not VAPs? Because that's what the Americans have done. They've taken out the objective measures and put in what are routine data. And it's probably good enough so that probably wouldn't be too difficult though, would it? Or do people not thinking of it in that way?
Do you know what though, Martin? Here's just another example where national surveillance is probably, like, I remember when SABs were first introduced at a national level, and all of a sudden we did have CEs asking us, what's this? What are our SABs? What's our SABC rate? Are we do? What's happening here? No one had ever asked us that before.
That's Staph aureus bacteremia for folk who aren't familiar with the term. Yeah. No data, no problem. So you collect data, and they will recognise as a problem.
Exactly, and I reckon that's part of the problem.
So no VAT data, no problem.
No problem. It's not there. Don't go looking for it.
Well, that hurts my soul.
It's kind of like the unknown knowns and the known unknowns, and a great example of that. Let's move on from pneumonia because it could be, we will be here, which is great. But I guess there were things that were rated important, and we talked about some of those: CLABSIs and Staph aureus bacteremias, bloodstream infections, etc. And then the feasibility and the usefulness was also measured, and it seemed that things like bloodstream infections, CLABSIs, seemed to be some of the most feasible and potentially the most useful, as determined by those who responded. Is that a fair assessment?
I think anything that relied on lab, everybody perceived to be easier and more feasible, because the lab would flag it in our system that we have across the state called Multiprac, and then they'd have to check it. So anything that required chart review, because a lot of our health services aren't in electronic medical records stage yet, they saw it as less feasible and less useful. Would you agree with that, Sal?
Yeah, and I think it's really important to flag here as well when it comes to feasibility. It was feasible right now. So feasible with your current resourcing, with the current systems, with the current organizational pressures. So what's feasible right now? And so, yeah, there is an absolute operational component to people's responses in terms of Multiprac, in terms of which is the platform that we use to do our surveillance. We also have one pathology system across Queensland, which is incredibly valuable to us and very helpful. So I think that's a really important consideration in terms of feasibility, because, I think if you ask people if they had all the resource in the world, what they would put as important, I think you would get different answers. But I think that's important to remember, that it was feasible with current circumstance.
And that's another little issue, isn't it? Because I often wonder about, we fit our program to what we have, not necessarily what the organization needs. So
100%.
An interesting question would be, if you had complete resource, what would you do? And then you go to your chief exec and say, okay, I've costed everything on this. I need one total time equivalent for that, and I need somebody for that, and I need somebody for that. And then you go to the chief exec and say, okay, this is the resource we have. What parts of this program do you want us not to do? And throw it up the organization so that you don't have to make the decision, you're not doing it. So if a regulator comes along and says, why aren't you doing VAP surveillance, when probably, your data says you've got a lot of people dying from VAP, it will be, well, because the organization chose not to fund it, whereas we decide ourselves not to do it. I do wonder if that's what we do. So a good question might be, okay, if you had unlimited, where would you work with this?
They also perceived a number of measures to be someone else's remit, so in particular pneumonia. So they would say, that's ICU, that's not us.
Yeah, VAT might be, but not necessarily HAP.
Yeah, considering 60% of it will probably be outside the ICU.
Yeah.
Okay, so then you went through the sort of consensus approach, and you ended up with 14, I guess, infection surveillance types or measures that seem to achieve consensus. What were your thoughts on that, Jess and Sal?
I wasn't surprised by many of them. I think the one that I was really surprised that didn't get up, that we couldn't reach agreement on, was the cesarean sections. And the panel was very much split down the middle. We had a lot of discussion about that. The significant organisms and the surgical site infections, I don't know across the rest of Australia or internationally, but surgical site infection surveillance is very labour intensive. And so participants on the panel were worried if they recommended a particular surgery to surveil that would have significant resourcing implications. So that definitely weighed into the discussion. And what we found was that if areas were having outbreaks of new organisms or they were increasingly problematic in their sites, they were getting weighted more heavily as well as something that we should target as statewide surveillance. So those emerging infectious threats, and we saw that with Canada. So I just wonder, what were your thoughts on the surveillance at Sam?
Yeah, I agree. I think there was a consideration, I suppose, definitely from the participants in terms of that impact and the load. And, I think there was definitely, if we see a risk here, we'll still do that. So it's important to, I guess, see this as a core mandatory collection, if for lack of a better word, or, core data set that has to be collected. And then obviously everyone can do whatever they want on top of that. But there was, I guess, just that restriction in terms of, even the cesarean sections, as Jess said, was quite variable. And there was a lot of discussion about how it's very difficult to do surveillance, or people feel like they're not doing surveillance properly. So if you're not doing it properly, is there any point? And those sorts of discussions. So, yeah, and it's cart and horse stuff, right? Because if you make it the core set, then obviously people will start to collect, and then there might be more of a push in that direction. You might get more resource to do it. But I think people were in the first instance quite concerned about adding too many things that were resource intensive, but then not necessarily getting the resource that would enable that to be done properly. And I do appreciate why people might be like that. And it is definitely why it's so important to have a process which is collaborative and which allows people to have those discussions back and forth, I think, in terms of methods.
And just thinking about those 14 agreed items, I think it was 14 or 13, 13 maybe. Jess, just touching on something you said earlier about lab-based related outcomes, or those that involve labs might be a bit more considered more feasible and useful. And just looking at that list, like C. aureus, for example, and there's vancomycin-resistant enterococci, and there's CPEs, and there's carbapenem-resistant Acinetobacters. Are we talking about infections here, or are we talking about colonization and numbers? And is that why these, if it's the latter, is that why these, do you think that would influence why these are in the set? Because you don't need someone to do them if it's just colonization, it's just lab data. Like, what was the differentiation between colonization and infection for some of these things?
That's a great point. We had a discussion about this today about a few bloodstream infections, actually. I don't really know is the answer. It didn't get raised, to be honest, at all in the panel. There was a discussion around it's easier to do the surveillance when it's based on pathology because you get an immediate alert from Pathology Queensland and it tells you to check that patient and look to check if it's a healthcare associated infection. So that definitely influences feasibility. But I mean, when you look at it, the majority of the measures are informed by a pathology result.
Yeah, because if it was infection, then you could argue, for example, if it was, a multi-resistant gram-negative, that could be in a UTI, it could be in a pneumonia, it could be in any of those types of things. So inevitably you're doing that type of surveillance. The other thing, perhaps, just while we're talking about, I mentioned UTIs there. I know in the discussion there was talk about UTIs and that's difficult, not feasible to do. Any thoughts on that?
Yeah, I don't know, Sal, if you want to touch on that, but I put UTIs, not in a loving way, in with VAP, in that they're so important to surveil, but we don't know how to do them yet. They're so resource intensive and there's so much noise in the surveillance process and result. People weren't willing to commit to that surveillance in the minimum data set because it would have significant impacts on resourcing.
There is a lot to be said for how resource intensive surveillance is still. It's obviously a bit of our passion. And I guess to pick up on what Martin said, you know, I think we're limited by our own fear around the impact of too much surveillance in terms of when you lift that rock up, what are you going to find? Because I think, you know, if we're realistic about it, we all know there's way more of an issue than we know and is articulated, and it's just still so resource intensive to do that work, and people are quite concerned. And I think there's, in some ways, Queensland is needing to move forward in that space and to harness some of the EMR stuff a bit better and look at how we can make surveillance easier and more resource friendly for people so that this isn't a big fear. But I genuinely think that you can see that in this study that people are reluctant.
Yeah, I was just wondering if there was any chance that the state may say these are the minimum data sets that we expect you to collect from an organisational point of view.
They have.
They have said that.
Yep.
Okay,
So they've been
well,
rolled out
that's a
as
start.
the 1st of January. So there's a lot of space and movement in that, but the 13 measures are considered the minimum data set for surveillance. And then there's optional measures in the caesarean section. And then obviously facilities will do beyond that what they're currently doing. So yeah, so it was really important that we had that wide consultation because that would obviously impact the uptake. And I guess just to touch on Sally's point of view, I shouldn't say this because it's our paper, but I almost feel like these results will be a moot point in 5 to 10 years because we'll have such data integration. Machine learning will be far superior to what we're doing now. You'll be able to have everything automated. I mean, what they're doing in the States with HOB, I'm sure you have opinions on that as well. But like, there's so much that can come from here. I think it's a stopgap measure while we work out where we are, what we can do.
That's a really good point.
I just have one last little question. That an annual point prevalence survey wasn't considered. And I've known plenty of people who thought, okay, we've got a limited resource. So if we do an annual point prevalence survey, that's what the data from that can help focus where we will focus what we can do with our current resource while we develop the systems elsewhere. And I know last week's podcast with Aileen Wolfensberger, out of their annual point prevalence survey, they found hospital-acquired pneumonia, non-ventilator associated, to be a big problem. So then they brought in this semi-automated system. But a point prevalence survey wasn't considered, or was it just, did it not come up in what people thought they should do at least once a year?
So we had a long talk about the different modes of surveillance people are currently using. And I think this links in really nicely with the risk assessment-based surveillance as well. So I think there would be argument for, I mean, annual point prevalence makes me a bit anxious. But even if you did biannual or something, and then maybe some targeted surveillance on the high-risk populations who had such severe outcomes. But that's a great point. And if it's been done well elsewhere, then we should definitely learn from it.
There's some interesting work going to be happening in Victoria shortly in Australia around point prevalence related.
I was going to say chat with Deb. Yeah.
Yes, that's an interesting piece of work that we will get Deb on. A few of us in the podcast are involved in that one too. So I guess next steps, Jess, you talked about, and so you talked about this being implemented, which is fantastic. And I guess the other interesting thing that we didn't really, maybe I didn't allude to at the start, was the authorship is diverse for this paper and included those in positions and roles that could be seen as influential to help the uptake of the findings of this research. So well done on that. I guess the next question is where to now for this? What's the next steps for you?
Well, Sally said I had to be polite, but I think we need to replicate it into national surveillance. So we had one consumer on our panel. I think if we're going to try, and like I've followed Phil's work for ages, and I think we have such a breadth of expertise in infection control in Australia and also in ID and micro. I don't understand why we can't come together and at least propose a minimum data set. I'm not naive enough to realize that has significant resourcing implications. But I do honestly, after undertaking this process with some very, and I say this very gently and with love, opinionated IPCs, I do think you can get them to agree when they hear each other's point of view and they're faced with a, can you live with, is this okay for now, sort of conundrum. So I think we could replicate this study, make it far better, engage more societies and more consumers, and come up with a minimum data set and really lobby the Commission to try and get behind that.
Can I just add one more? It sounds like that's a great way to finish, Jess. And I guess one of the things that I'd say to that, just in support of that, is if we don't get our act together, decisions get made for us. And a great example of that is hospital-acquired complication surveillance, in inverted commas. We started around for so long trying to do other types of surveillance and trying to get definitions. It took us years to come up with the Staph aureus bacteremia definition in Australia. And then as a result, it's quite easy for decision makers to go, you know what, you guys can't get your act together, so let's just use coding data. And we do run the risk of that happening again and again if we don't just get together and come to a consensus about some of this stuff and acknowledge that there are going to be differences, but we just need to ultimately agree on something. That's me on my high horse.
No, I love it.
So it's been a tour of soapboxes today.
Pneumonia is very important, Martin. And I'd just like to clarify, when I said opinion, I mean strong-willed.
Yeah.
Strong-willed, yeah.
Yes.
No, pneumonia, I think pneumonia is so important because of the amount of antibiotics used for a start. If we're trying to do something about antibiotic stewardship, reducing the number of people who actually get antibiotics has got to be a great place to start. And the tonnage and the secondary cases of C. diff you get because of the antibiotics, you know, it's just a no-brainer, really. But
UTIs aren't as sexy, though. Like, who wants to deal with urine?
And, you know, if we had good surveillance on...
I love sputum.
Are you taking the pee? That's not good. Yeah.
You know, and it'd be, you know, there's interesting when you do good surveillance on bloodstream infections, how many are actually coming from source being urinary tract infection as well. So
yeah.
Anyway, that's for another day.
We should write a grant.
Yes. Thanks so much, Jess. Thank you, Sally.
Thanks,
Great
guys.
chatting with you. Great work. Really, really like this sort of opportunity to get your thoughts on this and share them. And it's these kind of other sides to the story of the paper to papers that we really like to get. So thanks for sharing that and being quite open about some of the things you experienced. Martin, thank you. As usual.
I just one little comment. You guys are producing so many great papers and you've got so many great researchers in Australia. I can't believe you haven't got national definitions.
I can't believe we don't have a CRE.
We've even got them in Europe with lots of different countries and lots of different languages. So, you know, guys, you're so far ahead in so many other things. It's time.
Yeah, maybe it is.
Time.
Maybe we just have to bring everyone together. Maybe that's the answer.
Yeah, I mean, it's not as if you speak different language over there, is it? You know, it's...
No.
No. All right. Well, thank you, Jess. Thanks, Martin. And thanks, Sally. And thank you to everyone who's joined us for this episode of Infection Control Matters. It's goodbye for now.